You've made the hardest decision, looking for addiction treatment for someone you love. But right when you need clear answers, you hit a paper wall. Instead of straightforward options, you are faced with a very specific clinical vocabulary. Facilities advertise themselves as level 3.1, level 3.5, or 3.7 bio. These numbers come from the American Society of Addiction Medicine, or ASAM. When families see these numbers, they naturally assume it is a grading system. It is easy to think a 3.7 facility is simply a premium, higher quality version of a 3.1 facility, and that fighting for the highest number guarantees the best care. This diagram shows what those numbers actually represent. They map out the intensity of medical and clinical support required. The ASAM criteria is designed to place a patient in the least restrictive setting that can still keep them safe. Pushing for the highest number when it is not clinically necessary puts a patient in an overly restrictive environment. It strips away their daily autonomy, disrupts their ability to practice normal life skills, and dramatically increases the cost of care. Conversely, dropping someone into a low-intensity setting too early leaves them medically vulnerable. Without the right oversight, severe physical withdrawal symptoms can become dangerous, and the risk of early relapse spikes. Your goal during this process is not to find a facility with the highest score. Your goal is to find the exact level of intervention that balances your loved one's physical safety with their need for personal growth. This decision tree shows how professional assessors establish a baseline for care. They evaluate a patient's situation by splitting it into two distinct paths: immediate physical medical needs and ongoing behavioral clinical needs. The structure of a treatment plan hinges on a direct trade-off. Standard residential care provides patients the autonomy to rebuild life skills and practice daily routines. Inpatient care takes that autonomy away in exchange for hospital-level physical safety. This brings us to the first rung on the residential ladder, level 3.1, known as clinically managed low-intensity residential care. Assessors recommend 3.1 for patients who are entirely medically stable. These individuals do not need physical monitoring, but they currently lack a safe, sober, and supportive living environment to anchor their recovery. Placement at this level usually looks like transitional housing. The patient lives in a structured peer community and receives several hours of dedicated clinical therapy each week. Level 3.1 offers vital daily structure. However, if a patient is experiencing severe behavioral instability, the few weekly hours of therapy provided here will not be enough to keep them safe. You can think of 3.1 as a secure launchpad for practicing real-world independence. It is an environment for building recovery skills, not a setting for managing an acute psychological crisis. When a patient requires deeper behavioral intervention, assessors look to level 3.5, clinically managed high-intensity residential care. A 3.5 patient struggles heavily with daily functioning. They have complex mental health issues requiring round-the-clock structural support and daily therapy. Crucially, they do not face dangerous physical withdrawal risks. This level provides an immersive environment for psychological recovery.
But because it is clinically managed, not medically monitored, it is unequipped to handle a sudden physical health emergency. If physical risks are present, the assessment shifts entirely to the medical branch of our decision tree, to level 3.7. Medically monitored intensive inpatient care. A 3.7 assignment is reserved for individuals who require supervised detox. Withdrawal from substances can trigger fatal physical reactions, making 24-hour nursing care an absolute requirement. You may see this written as 3.7-bio. The bio designation indicates a facility equipped to manage severe, co-occurring physical health conditions alongside addiction. Level 3.7 ensures physical survival during detox. Because of this medical focus, the environment is highly restrictive. Crossing the line from a 3.5 residential facility to a 3.7 inpatient unit is a transition from intense psychological support to acute medical life-saving intervention. No one stays at a single ASAM level permanently. These numbers are dynamic prescriptions that shift as the patient stabilizes. This graphic shows the process known as stepping down. As a patient clears a medical crisis, their team transfers them to a less restrictive level. A highly effective path starts at the top, completing a 3.7 detox, then immediately stepping down into a 3.5 setting. Families often find this frustrating because stepping down means dealing with new intake paperwork or moving to a different facility, but that friction is a necessary part of recovery. Moving down the ladder forces a patient to practice true independence. When you see a patient stepping down, or even stepping back up if they experience a setback, it proves the ASAM criteria is working exactly as intended to meet them where they are. You do not need to memorize the clinical criteria to diagnose your loved one. A licensed program assessor will conduct the official evaluation to determine their proper level. Your role is to act as an informed advocate. You can use your knowledge of their daily habits and physical health to ensure the assessor places them accurately. If your loved one has complex, ongoing physical health issues layered with their addiction, advocate for a 3.7 bio evaluation. If they need to safely detox from alcohol or benzodiazepines, tell the assessor they require the medically monitored withdrawal of a standard 3.7. If they are physically safe but mentally unstable and unable to function, look toward 3.5. And if they are stable but simply need a highly structured bridge back to normal life, 3.1 is the target. This shows an advocacy intake checklist. You can use these specific questions when interviewing a facility to prevent mismatched placements and sudden unexpected transfers. First, ask directly, is this facility equipped to handle medically monitored withdrawal, or do you only provide clinically managed care? This clarifies immediately if they can handle a physical crisis. Next, ask them to outline their specific timeline and protocol for stepping a patient down to lower levels. Finally, if you are seeking bio-level care, confirm that a physician is actually available 24/7 on the premises. Addiction treatment requires constant adjustment. Understanding these numbers up front helps you ask the right questions, avoid disruptive mid-treatment transfers, and secure a much safer path to long-term recovery.